Hello, my name is Amy Coble. I'm the State Director of Child Abuse Investigations with the Tennessee Department of Children's Services, and today I would like to talk to you about the collaboration between hospitals and DCS staff. Every Tennessean is a mandated reporter of child abuse. Each year, there are over 70,000 child abuse cases assigned for investigations of abuse or neglect. Tennesseans must report child abuse to the Child Abuse Hotline for suspected cases of abuse. For medical professionals, the hotline has provided a dedicated line, and that number is 1-877-237-0026. Abuse and neglect allegations can include physical abuse, sexual abuse, neglect, psychological harm, and death. Drug-exposed children fall under the physical abuse definition. A drug-exposed child is defined as one who is under the age of 18 and has been exposed to or is experiencing withdrawal from the use, sale, or manufacturing of a drug or chemical substance that would adversely affect the child's physical, mental, or emotional functioning as a result of the actions or behaviors of their parent or caregiver, or a parent or caregiver that uses drugs or chemical substances that impacts the ability to adequately care for the child. Also, the parent or caregiver has a current addiction issue that would affect the child's physical, mental, or emotional functioning. With the enactment of the Comprehensive Addiction and Recovery Act, the Department investigates drug-exposed infants who are affected by substance abuse or those babies suffering from withdrawal symptoms resulting from prenatal exposure from the use of illegal drugs or the misuse of legal drugs or chemical substances and are diagnosed with neonatal abstinence syndrome and fetal alcohol spectrum disorder. Prenatal exposure of illegal drugs or the misuse of legal drugs should be reported to the Department of Children's Services. If the child is diagnosed with neonatal abstinence syndrome, this constitutes a mandatory report to the Department of Children's Services. Mothers who are receiving medication-assisted treatment do not always constitute a referral to the Department of Children's Services. For example, if the mother is prescribed a legal medication, however the child is not diagnosed with NAS, this would not constitute a referral. During the investigative process, the caseworker is responsible for investigating the allegation brought to the attention of the department. In addition, the caseworker will assess if there are other concerns or needs of the family. The role of CPS is to obtain key evidence to support the outcome of the case. Actions that can be taken are immediate action, long-term planning or services, and court involvement if necessary. The caseworker is also responsible for identifying if the mother, father, or other caretakers in the family need services. If service needs are identified, the caseworker can then refer the family to community or DCS provided services. It is helpful for families to know that even though the department will be involved, services will be sought to assist them so they can safely maintain the child in their home, or that a temporary placement can be sought to place the child in while they are receiving services, and then the child can be safely returned. If there is no less drastic alternative for a child, the caseworker will recommend and seek guidance from the Department of Children's Services legal team to remove the child and place them into foster care, at which time the department will petition for custody of the child and remove the child from the parent or caretaker. The Department of Children's Services instituted a hospital protocol. The purpose of this protocol is to ensure that hospital staff who are involved with children and families supported by the department are considered team members and therefore should be included in the planning and decision-making process. This protocol is to be utilized by all case managers, including Child Protective Services, ongoing non-custodial, and any custodial staff, including foster care and juvenile justice, to promote effective communication. Once DCS receives the referral, it is the expectation of the caseworker to make contact with the hospital within 24 hours of the receipt of the referral. This may be by phone or in person. If the initial contact is by phone, a face-to-face contact will follow. The purpose of the contact is to discuss safety concerns, obtain medical information and discharge planning, and coordinate timely sharing of information between DCS and hospital staff. The worker will begin discussions with the mother, father, and other caretakers involved in the case. Once the initial safety assessment is completed, the worker will determine the appropriate action step with his or her supervisor, DCS legal, law enforcement, or other parties. This process may include a child and family team meeting to be held with all parties to discuss the next steps. In some cases, a voluntary immediate protection agreement is implemented with the agreement of all parties. An immediate protection agreement is a temporary agreement between the Department of Children's Services and the parent or caretaker. This allows for the infant at risk to be safely cared for should the parent be unable to provide said care. This agreement may allow another party to obtain care of the child on a temporary basis. Once the agreement is complete, it should be shared with the hospital. If the case does not require an immediate protection agreement, a plan of safe care can be completed upon receipt of the case. Please take note that if an IPA or immediate protection agreement is completed, a plan of safe care will be developed subsequent to the immediate action. Through a child and family team meeting, the team will create a plan of safe care to address the long-term needs of the child, mother, father, and/or other parties involved. The purpose of the plan of safe care is to identify a permanency goal and develop a plan that specifies what must occur in order to achieve the goal, what services will be provided, and the timelines for achieving the goal to safeguard and enhance the welfare of children and to preserve family life, prevent harm and abuse by strengthening the ability of families to parent their children effectively. The plan of safe care lists specific tasks to include observable, measurable outcomes, as well as the names of persons responsible for the completion of each task. This is to include responsibilities of the family, the department, and other community resources, including the provision of services and monitoring progress. The Department of Children's Services partners with families, their support systems, service providers, community partners, informal supports, specific interventions and services to develop a plan of safe care during the child and family team meeting. The family and all participants will receive a copy of the plan of safe care immediately following the meeting. During the investigative process, the caseworker relies on partners to gather information and make the appropriate decisions regarding the situation. Depending on the severity of the case, some of the following may be partners working collaboratively with the Department of Children's Services. This may include the Child Protective Investigative Team, law enforcement, the district attorney, juvenile court, and other significant community partners include alcohol and drug treatment providers, health services, behavioral health services, other contracted providers, and community resources. Communication is the key to the success of each child and family. I want to give you the specific hotline number for medical professionals one last time, 1-877-237-0026. Remember, reporting abuse and neglect is critical to the safety and well-being of children.
Hi, my name is Erica Rodriguez, and I am an outpatient social worker at the Vanderbilt Center for Women's Health, and I'm here to talk to you today about an outpatient social worker's role in the treatment of opioid use disorder in the setting of pregnancy. The purpose of today's presentation will be to outline the role of a social worker during the intervention phase of opioid use disorder, and we're also going to identify trauma-informed approaches that can be applied through outpatient care. Additionally, we're going to discuss how teams who may not have a social worker can continue to provide adequate care for mothers living with opioid use disorder. In treating mothers with opioid use disorder in the setting of pregnancy, we really want to have a team approach. So ideally, you're going to have a team with multidisciplines, such as doctors, nurse practitioners, nurses, and social workers, in addition, the patients. Some elements of an exceptional team would be to maintain open communication with team members and patients. We also want to be mindful of confidentiality. A good way to maintain open communication are case conferences, maybe morning or evening huddles. Those can be very beneficial in maintaining that open communication. One team understands what the day team understands what the night team is doing, and so on and so forth. In addition to that, we want to maintain continuity with each patient as far as boundaries, limits, and expectations. The day team should know what the night team is doing so that the patient understands what is expected of them. Now I'm going to discuss with you what a role of a social worker is. A social worker becomes involved when a evidence-based screening tool such as the 4Ps or 5Ps indicates that an intervention or referral to an outside agency needs to be made. We do this by assessing for any barriers to treatment, such as transportation, housing, food, or violence in the home, or any type of motivation they have for treatment. We're also going to provide psychoeducation to patients, and we're going to further their understanding of their newly diagnosed opioid use disorder. Additionally, we're going to advocate and reduce stigma for patients during the antepartum, intrapartum, and postpartum periods. And by doing that, we are providing psychoeducation to the patients as well as the providers. Lastly, we're going to assist providers that may not have a dedicated social worker in their program with resource mapping. Now we're going to talk about the barriers of the outpatient social worker's role. These are some barriers you may experience as a social worker. First, systemic barriers, such as health insurance, prior authorization denials, reliable TennCare, and transportation carriers. Specifically, with the TennCare transportation carriers, it might be that they aren't bringing your patients on time to appointments. Additionally, governmental regulations such as Medicaid packages that aren't being expanded in your part of the state. Additionally, the most prevalent barrier to the role that I see is the stigma of OUD, specifically in families and the patient support network. Lastly is communication with different social services agencies, such as DCS, WIC, and legal systems. Now that we understand the role of a social worker and the barriers that come along with it, next we will assess the patient. A full psychosocial assessment includes living arrangements, relationship status and the role of the father of the baby, employment history, legal history, mental health history, which also includes trauma history, substance use treatment history, parenting plan, and the patient's overall motivation for treatment. Earlier, we mentioned psychoeducation for patients. This is what that looks like. By providing psychoeducation for patients, it helps patients and often their support system understand the diagnosis of OUD. With that, we're going to decrease stigma. We're going to provide referrals to treatment. Additionally, we're going to discuss internal level of coping skills and external resources, community resources that are available. Lastly, we're going to discuss the patient's areas of strength while also fostering their self-determination. This is how social workers can advocate and reduce stigma. Advocacy is made throughout the antepartum, intrapartum, and postpartum periods through the following actions. Decrease stigma with the use of proper language to educate others about OUD. Coordinate care with social services such as DCS, WIC, and legal systems, and create warm handoffs to inpatient staff and other social services as needed. As part of a social worker's role, we assist with resource mapping. Resources should be tailored to the patient's level of care, such as intensive outpatient programs, IOP, outpatient programs, OP, partial hospitalization programs, PHP, or residential treatment centers, RTC. Additionally, we want to refer patients to a convenient location to minimize any barriers for consistent treatment. Lastly, we want to verify if the patient's insurance is accepted at the care facility. The trauma-informed approach is one that social workers can employ. A trauma-informed approach includes looking at safety, trustworthiness, empowerment, choice, and collaboration. Safety is looking at time, place, and location of where treatment is provided. Trustworthiness means outlining every aspect of treatment and sticking to it. Empowerment is allowing patients to be affirmed and validated. Choice is to provide clear and appropriate rights and responsibilities of treatment. And lastly, collaboration. Patients should be utilized in mapping their treatment plan and making treatment decisions. What if your team doesn't have a social worker? If your team doesn't have a social worker, you can utilize nurse case managers through the patient's insurance, or you can utilize available resources in your area that offer social services for pregnant mothers living with OUD. Thank you for watching this video on an outpatient social worker's role in treating OUD in pregnancy. I hope it was helpful.
My name is Amber Dillahay. I'm a licensed clinical social worker with Vanderbilt Medical Center. Today I'm here to talk to you about the social worker's role with the opioid-dependent woman and the opioid-exposed newborn. This is from an inpatient perspective. So I'd like to start out by talking about how social workers in the healthcare setting are an integral part of the interdisciplinary team in caring for pregnant and postpartum opioid-dependent women and their infants. We're ideal in creating stigma reduction strategies, peer and professional supports, and comprehensive coordinated care. We can provide ongoing mutual support to decrease stigmatic responses, shame, and confusion. We can also support treating the mother and infant as a dyad and facilitating understanding and communication between the pregnant woman and her healthcare provider. So we can receive referrals in different ways. The inpatient social worker can receive referrals directly from prenatal clinics. We can also receive referrals placed by inpatient physicians, nurse practitioners, pediatricians, and nurses. The inpatient social worker completes a postpartum consult on all women with opioid use disorder. So now I'd like to talk about guidelines for the psychosocial assessment. The purpose of this is to obtain a pertinent history on the patient and to identify strengths or problem areas of concern. What are her living arrangements? What's the employment history? Is she currently employed? Is she financially stable? What's the support system look like? Does she have people at home to help her care for her baby? What's the role of the father of the baby? Is he involved or is he absent? Will she be a single parent? It's important to get a good picture of the mental health history. This is really important as many of our patients are dual diagnosis. So we want to assess for any history of depression, anxiety, or bipolar disorder. What's her substance use history or treatment history? We want to assess her adherence and engagement with the treatment program that she's enrolled in. It's important to get an idea of the custodial status of any other children. Does she have custody of her children, or is there a history of non-custodial status of her children? Does she have a DCS history? It's important to get an idea of her legal history. Also, assess her learning styles and learning abilities. Are there cognitive delays? Is there a learning disability that we need to consider? What are her feelings surrounding the baby and bonding with the baby? What are her feelings about parenting? Does she desire to parent, or does she want to choose an adoption plan, perhaps? Also, what is her coping style? Has she made preparations at home for the baby, or has she had challenges with this? These would be concrete things like car seat and a crib. So next I want to talk about the guidelines for our interventions. A big part of what we do is provide psychoeducation about opioid use disorder and neonatal abstinence syndrome. Psychoeducation is an evidence-based therapeutic intervention that provides information and helps support our patients to better understand and cope with their illness. We should also engage the family and or the support person if the patient is receptive and provides us consent, so that the entire family is informed. We also provide psychoeducation on baby blues and postpartum depression. Most hospitals will have a depression screening tool that's validated, such as the Edinburgh Postnatal Depression Screen. Those scores really help guide our interventions for patients. We develop a safe plan of care for mom and baby. This may include referrals to inpatient and outpatient treatment facilities, outpatient mental health care, also things like mom support groups and home visitation services. These are long-term supports that can really help our families thrive. We also provide additional community resources like food stamps and WIC. So we've talked about the assessment and the interventions. Now I'd like to focus on collaboration. Of course, we always want to include the mother in the collaborative plan and also her support system. We also want to ensure timely communication of the social work assessment to the healthcare team and assist in the development and modification of the plan if necessary. I'd really like to encourage you to get to know and develop relationships with your OBs, pediatricians, and other members of the multidisciplinary team. Working together, we're going to have the greatest impact with these families. So we've talked about the assessment, the interventions, how important collaboration is. Now let's talk about how we get there. Here are some helpful approaches for you. Of course, we always want to strive for a strength-based and trauma-informed approach. Empathy is also key, treating people with dignity and respect no matter what their circumstance. There's also cognitive behavioral therapy and motivational interviewing. Cognitive behavioral therapy seeks to help patients recognize, avoid, and cope with the situations in which they are most likely to relapse. With motivational interviewing, this capitalizes on the readiness of the individual to change their behavior and enter or continue treatment. So we're all going to encounter challenges and barriers. Here are some that I've encountered that I wanted to discuss. Your patient may be incarcerated, so she may be in police custody. So there may be a need for you to intervene on behalf of the infant and determine a safe plan of care for the infant at discharge. There may just also be a lack of needed resources for whatever reason, due to distance, bed or room availability in a treatment center, and/or cost of services. There may also be ongoing struggles with relapse, which may require consideration of a consult with Children's Services due to overall parenting stability. There may also be acute psychiatric or mental health concerns. The woman may need a higher level of care, so you may need to reach out in your community and see what resources are available. I hope you found this content helpful as an inpatient social worker working with opioid-dependent women and the opioid-exposed newborn.